Good morning. Too long. We talked about that American Indians and to a lesser degree Asians have a inadequate supply of those dehydrogenase that breaks down alcohol, so they tend to get inebriated faster. Also genetics, the offspring of alcoholics are 4 to 10 times as likely to become alcoholics as those of non-alcoholics. I think that's really important information to have if you come from a family with a number of alcoholics. It just helps you to realize that you may be predisposed to having problems with alcohol, even if you think you are drinking lightly or moderately. Also, females have a different ratio of muscle to water in their bodies than both men, and females tend to become impaired with a lower blood alcohol content than males. And my Mr. Barr from IT has come in, so we're going to see if he can work any magic.
Mrs. Martinez, it still hasn't ever sent your computer screen to us.
Okay. We'll push that button again. Gosh.
And it worked that time. Thank you.
Okay. But now we don't have it. Now it's gone and eaten, but maybe. There it is. Okay. So, I'm really just hitting buttons and mad at me. Okay, so I think this is where I'm supposed to be. I'll stop before you get busy. Intoxication is a reversible syndrome that symptoms following excessive use of a substance, and the symptoms are drug specific and occur shortly after ingestion. So the symptoms of intoxication from marijuana would be different than those from cocaine. That's what the drug specific means. There is a direct effect on your central nervous system and a disruption in your physical and psychological functioning. Judgment is disturbed. Social and occupational functioning is impaired, even if you don't realize it. And also, interesting, fun little fact. It's running? Great, thank you so much, Adrian. The lecture capture has started in, so I'm sure you all are happy to hear that. Yep, it is, thank you. Alcohol intoxication is a factor in 1/2 of homicides, suicides, and traffic fatalities. So that's something to give thought to. We don't have firm statistics on marijuana, but Colorado has had an increase in car accidents since they legalized recreational marijuana. So I don't know about Oregon and Washington, other states that have had it for a long time, but there's going to be more research as time goes on to tell us more about how that may be affecting those states that are allowing recreational use of marijuana. Okay. So the experience of substance withdrawal, physiological that accompanies the discontinuation of an addictive substance. And I underlined abrupt here, but what I really wanted to do and didn't know how was draw a line through abrupt. Because I think the book said abrupt reduction or discontinuation, but then when you start reading, it occurs with even gradual. People do have some rough adjustment regardless. It's worse if they stop abruptly, but it's not just magically easy if they taper off. Okay, so most of the time there are fairly significant physical signs and symptoms and psychological changes in thinking, feelings, and behavior. So talking about central nervous system depressant withdrawal. Withdrawal from depressants such as alcohol, benzodiazepines, and barbiturates can be fatal. Withdrawal from other substances is unpleasant, but not considered to be fatal. I guess there's always that 1 in a million chance. But things like cocaine, methamphetamine, hallucinogens, inhalants, withdrawal is unpleasant, but it does not require medical supervision unless that person has some sort of health problem. So opioid withdrawal, we'll talk about that a little bit more. It makes people pretty miserable, but not at risk of death. And that's on table 31.3. So more about alcohol. We're going to talk about alcohol a lot because it is, I really like this lecture in general because I think substance abuse is probably one of the most significant health problems we have in our country. I think it affects more people when you read the statistics than practically anything else. And there are a lot of deaths associated, especially when you think about the homicides, the suicides, the car accidents. So it, besides destroying the body, it does a lot of other things too. So the central nervous system effects are proportional to your blood alcohol concentration. Most states, legal intoxication is 0.08% blood alcohol level. And your body burns about a half an ounce an hour. That depends on your size, your physique, of course. Also the presence of food, your gender, how muscular you are, can alter that metabolism. But people who drink fast, who have a couple of cocktails pretty quickly, can get intoxicated very easily because your body can't break it down that fast. So it's the most widely abused drug in the United States. It's considered the nation's #1 health problem. Third leading cause of preventable death. I know you can read this. There's quite a bit of binge drinking, and I've had some mirror statistics, but I didn't think I had them for the 12-year-olds, so I didn't update my slide. So that's pretty sobering, huh? Pun intended. When you read those statistics. Okay, so damage to the liver in late-stage alcoholics. That liver will use the alcohol and bypass its normal energy sources. So fat accumulates in the liver and the bloodstream, and you develop a fatty liver, which can turn into cirrhosis and hepatitis. You also get hyperlipidemia. We know that hyperlipidemia can contribute to heart attacks, to strokes. So that's a bad thing that actually originates in the liver related to alcohol use. So it's not just that the liver gets scarred and cannot digest well, but these affects other body systems. The things that don't happen properly in the liver hurt other body systems. And this acetaldehyde accumulation in the liver damages and destroys that organ. So that ends up eventually destroying the liver over time if people continue to drink heavily. Tolerance. Sometimes people brag about this, that they can drink someone else under the table. I'm sure you've heard that phrase. That is a bad thing. I had this conversation with my adult children not long ago.
Cool.
Why are you laughing? Y'all think it's a bad thing?
This is funny.
It really is. Take my word for it. really, it means that that person has become accustomed, for the most part, to alcohol, and it takes more and more alcohol to demonstrate impairment. So they have had some cellular adaptation and an increase in the hepatic enzymes that work on alcohol. But so their liver really starts kind of neglecting its other duties and paying more attention to alcohol. So tolerance to the depressive effects of alcohol, and these I mean respiratory depression, do not decrease. So even though they can drink more without appearing to be intoxicated, they're equally at risk for death from a respiratory arrest as an infant drinker is. Most people don't know that. So some of the things that happen to your body and other body systems, in addition to your liver, in the esophagus, there is increased hydrochloric acid. There's an increase in oral cancer and esophageal cancer, and the vessels, the blood vessels, tend to get engorged around the esophagus because the flow is impaired from the liver, so it backs up to these vessels around the esophagus, and when they start bleeding, sometimes a person will bleed out. It's hard to get them to stop. And one of the reasons for that is that your liver's clotting factor, its participation in how our clotting factors work is impaired, and alcoholics tend to have thrombocytopenia and do a lot of bruising. So sometimes you'll see someone who says, I don't know where this bruise came from. Now, it's not always because of alcohol, there's other reasons, but alcoholics tend to bruise very easily. And that's related to that cirrhosis of the liver. So, gastritis, this, we don't think of the stomach as being life-threatening and contributing to a whole lot of big problems, but actually, with an alcoholic, there is, gastritis means there's a lot of inflammation in the stomach, and that impairs your vitamin absorption. In particular, the B vitamins and B1, which is thiamine, worst of all. So you get a lot of problems from that thiamine deficiency. It affects your nervous system, both your peripheral nerves and your central nervous system from that thiamine deficiency. They're also prone to GI bleeding and stomach cancer. Lots of nausea, vomiting, distension, just generalized misery. The pancreas, you can have acute or chronic pancreatitis. You're also, because the amylase and lipase, which are enzymes produced in the pancreas, basically start digesting the pancreas itself over time. The digestive enzymes, they will attack the pancreas, and that is very painful. Person with pancreatitis is NPO. Generally, when they're hospitalized, they're on IV supplement. They can't even have tube feeding, so they have to have hyperalimentation, is I think the old term for it. But we have to feed them through their IVs until it subsides. So we have to rest the pancreas. And they're also very prone to developing diabetes because of the pancreatic problems that come with alcohol use. So we talked about the liver there. We talked a little bit about the esophageal varices. Seizures can happen most often when they try to withdraw, but the seizures have to do with the central nervous system impairment, and it can also have to do with respiratory depression, lack of oxygen, can affect the heart, so that you'll have a acute cardiac event, a myocardial infarction. Can also affect the brain, and it has a lack of oxygen that can bring on seizures as well. And when seizures are severe, basically the person can stop breathing for several minutes, so that can cause the death. the peripheral nervous system. People have peripheral neuropathy that's very painful. That stems from lack of absorption of B vitamins, and that includes folic acid, niacin, B6, B12, all of the B vitamins. So part of it is lack of absorption, part of it is poor nutrition. People who drink a lot usually don't have much appetite for food. They're kind of full. And they may have ascites or distension in their abdomen, so that makes them feel full even when they're not. So typically they have poor diets, so they don't eat well, but even if they do eat well, they don't absorb it well. So it's a double-edged sword. You also have muscle wasting, which is called myopathy. So a lot of your late-stage alcoholics have very skinny arms and legs and big bellies. That's the look I know we're all going for, right? That's what we want to do. So brain damage. Several things contribute to the brain damage. There's elevated ammonia and bilirubin levels from the liver failure, and the lack of the thiamine and other B vitamins. B vitamins are essential really for our brain to function properly. So we have brain malfunction from those as well. The brain, if they do a CT scan, it's smaller. In someone who has abused alcohol over a period of time, they can actually see atrophy. The eyes, people lose their night vision and peripheral vision. I don't know the physiology behind that. Let's just copy that one out of the book. We talked about hypertension. Well, hypertension leads to cardiomyopathy, among other things. It contributes to heart attacks, you know. But cardiomyopathy is that enlarged, floppy heart that really doesn't have a strong muscular pump. It's just a big floppy, sort of like a basketball or soccer ball that's not inflated. It doesn't do much of anything. Sexually, usually impotence, low testosterone levels, testicle shrinkage. Women alcoholics have lower hormone levels and decreased sexual interest as well. So we know pretty much, we've observed people who were intoxicated. We've probably dealt with them if you worked in an ER, or you might even see them in Walmart or all about the community. There may be a inhibition. So if they were normally an inhibited person, and they would know to inhibit aggressive or sexual impulses, that's gone. So they might act on impulses they would not act on if they were sober. They can have very labile moods, be very emotional, up and down, cry for no reason, or be very laughing at things that aren't necessarily funny to anyone but them. Generally impaired judgment, which leads to driving a lot of times when they shouldn't. Impaired social and occupational functioning we talked about. So all of these things you know. The asterisks there at the bottom are that if this person might be on a central nervous system depressant, maybe a prescription medication, and they mix it with alcohol, that combination increases the respiratory depression, and it can certainly increase the likelihood that they're going to die. If you hear a sound like shuffling of papers, that would be because I am shuffling paper. It's not a mental thing with you. So, if most of you, I think, can do this on your phones. I can go outside of my slides, but tell me if I need to, and you can share phones to do this. I want you to go to a website, and it was mentioned in your textbook. So this is going to be one of our classroom activities. It's called, Rethinking Drinking. It's all run together. So it's www.rethinkingdrinking.NIAAA dot NIH dot gov.
It's on page 374.
It's on page 374, Kate. And what I want you to do when you get to that website is pick a drink. And if you don't drink, just pick one for whatever reason. Pick one you've heard of. Margarita's on there, pina colada. The first time I drank a pina colada, it was because my sister had one and it looked kind of like a frozen ice slushy thing. So, and it smelled good, pineapple, so I tried it.
Where do
So,
you pick it?
Pick,
You search for it? Or
um,
at the bottom, I think, of the,
if you scroll
how
down,
strong is your restriction?
and I want you to figure out what your blood alcohol would be if you had one of those drinks, two of those drinks, or three of those drinks in 1.5 hours. So you'll have to scroll around a little bit to figure out how to do that, but it's pretty easy going. It will ask you your weight and a couple of things, and then it will calculate for you. But you have to first look at the drink, check, click on the drink and see what the alcohol percentage is and how many ounces is in an average drink if you walk into Chili's and order a margarita. I think it might have been 9 on the margarita, I don't know. So you'll have to know how many ounces and then what the percentage of alcohol is in order to do this. And no one will see it but you, so you could put in your actual weight. You're not turning this in.
I don't see where it is, yeah. Which one is it, the blood alcohol concentration?
Well, first you have to click on the drink. You have to pick a specific drink first, and then you can do your blood alcohol calculation. Cause you won't know the ounces or the alcohol percentage unless you choose a drink first.
Oh, so, okay.
Okay. There's only so many there, so. If you don't
find
drink, just choose a random one that you've seen or heard of.
We'll figure it out, right?
Yeah. Go into the calculate your blood alcohol content.
I didn't see that one though. This is the first one.
I think it's on the right-hand side.
There's more alcohol in my drink than others in the mixers.
Okay.
I was really shocked by this.
And then
I-
blood alcohol concentration?
1.5 hours. Yeah, you're gonna sit down for 1.5 hour, and you're gonna calculate it for one drink, and, you know, write down what your blood alcohol percentage would be, and then you're gonna punch in 2 drinks, and then you're gonna drink 2 in 1.5 hours, and then you're gonna do it for
Yeah, but how much is your drink worth?
I think so.
So basically, we should just keep on doubling the content. If you have 2, you just double it.
Do you?
You said it was on the page, Katie?
That's what I'm saying, is it
Well,
2
it's on the
two
page.
drinks in 1.5
It's
hours?
on page
Okay,
374,
so
the
basically-
website. It's right here.
It was shocking to me that just one drink that you buy in a, you know, like a Chili's restaurant or something. Because I think of one drink as being that 1 ounce of alcohol, but actually a margarita or a pina colada or something in one of those restaurants has, more alcohol in it than that.
What else am I supposed to do?
Have you got it even for one drink?
I'm confused.
I
did, but.
So what am
Wait
I,
a minute, I'm asking him.
what am I figuring out? Because I just found out how many one drink is in total.
Now you go to blood alcohol, calculating your blood alcohol.
What are the hours?
Withdrawal. For someone who has a heavy user of alcohol, a lot of maybe sleep 7 hours, and immediately have a mixed drink. That's not just because they like it, got for breakfast, it's to stop withdrawal. They may have tremors, they do not feel well, and, you know, they've got this muscle weakness and malaise, so they're grabbing that morning pick-me-up to ward off withdrawal. And that's a sad thing too. Basically, they start withdrawal every morning, or every noon, whatever time they wake up. It depends on when they stop drinking, I guess. So, and there are lots of things that you can read here for yourself about what withdrawal feels like. The worst thing about it is probably on the next page. Nope, I'm going the wrong direction. I can't go left and right today. Okay, alcohol poisoning. We know this happens every year at some frat house or some college around the country. It is a very, very sad thing. It often involves someone who never touched a drop of alcohol in high school. That happened to someone in Garfield County, that was in my daughter's class. He was very much from a teetotaling family. He did not drink in high school. He went off to college on the East Coast, and he was hospitalized with alcohol poisoning like the first week during that place. And he did not die, fortunately, but he could have. So, it can be from respiratory depression, it can be from cardiovascular arrest, or just arrhythmias, going to coma, seizures. So, the immediate management is thiamine, IM, getting respiratory support, being prepared to ventilate that person if you need to, holding their airway open, IV access, cardiac monitors, vital signs, that sort of thing. And this little bullet about disulfiram probably shouldn't be on this. It should be on a different slide, but you can make note of it. But it just says that medication should not be given until that person has abstained for at least 12 hours, because the combination of alcohol and disulfiram makes them very, very sick. So if they should be someone who says, I want to take that medicine that will make me really, really sick, that is a deterrent to drinking alcohol, they have to wait at least 12 hours if the doctor writes them a script. They have to be taught to avoid, mouthwash, to avoid food, like sometimes you see in a restaurant something that's cooked in a wine sauce, a white wine sauce or something, red wine sauce. They really need to read labels, but be very careful if they eat out and make sure they don't eat something that has alcohol in it, because they can get really, really sick. Even, it said in your textbook, skin bracers, and I'm like, what's a skin bracer? But it's something like maybe a toner, something that has alcohol in it, that's something for your skin, maybe to dry up big pores or something. They can absorb enough alcohol to get really, really sick if they're taking disulfiram. So they have to be careful about that. I don't think they use this medicine much anymore. There's some newer medicines out there. And they need to take a B complex vitamin. Anyone who is a drinker should take B vitamins every day, absolutely. We probably all need a multivitamin, but they need a multivitamin plus a B complex. And then there's some self-help organization information here. Wait a minute, let me go back here. So, about the thiamine and the B vitamins, I did say that first dose is IM. They also generally get if they're in the ER, they get what we call a banana bag. It's 1 or 2 liters. And it's yellow. That's how it got the name banana bag. And it's usually given like around 250 to 500 cc's an hour with all kinds of vitamins in it. So I was going to Google what all is in there, but it's just tons and tons of vitamins. This is to ward off Wernicke-Korsakoff syndrome. And that's that confusion and, memory loss and brain damage that comes with heavy drinking. And some textbooks call it two different syndromes, Wernicke and then Korsakoff. Korsakoff being the long-term irreversible part, Wernicke being something that if you give them the vitamins and they stop drinking, it, goes away and doesn't come back. But more and more, you're seeing it as one syndrome. So, not gonna ask you a test question about whether it's one or two, because that's kind of, okay. And the answer is, I don't know, because it depends on where you read about it. Okay. The most famous, I guess, self-help organization to treat alcoholism is AA. There's also a Al-Anon for family members. There is,
Miss-
yes,
We have a student that has a question.
uh-huh.
Is that reversible?
The Wernicke-Korsakoff, if they have been a long-term alcoholic and a very heavy drinker, even if they stop drinking, generally they have, some components of that are not reversible. They're probably never gonna have the short-term memory that maybe this person is 60 years old and they've been drinking for 40 years. If you compare them to 10,000 non-drinking 60-year-olds, they probably will never have as good a short-term memory. They may have some other, if their brain has atrophied to a certain extent, it's not gonna grow back. So they're gonna have some long-term permanent deficits. But if they, have been a heavy drinker maybe for 6 months, maybe they haven't had permanent damage. But for a lot of, people who drank heavily for 20, 30 years, some of it is permanent. Yeah.
Thank you.
Uh-huh, good question. Okay, so, really the purpose of Alcoholics Anonymous, and with, you don't need a textbook to know this really, is to help that person, for them to help themselves by going, to maintain their sobriety. And the members try to help each other, support each other. They have a coach of some sort, and when they get to a certain point, certain length of sobriety and health, they generally take on that role as a peer support for someone else. The idea is that they'll have 24/7 access to someone who has walked in their shoes, who can talk them out of drinking. When they want to drink, when they got, something happened, there was a big layoff on their job and, their house burned down, something bad happened, and their first reaction by nature is to go drink. But, there's somebody that's gonna help them. What do you think the biggest challenge initially to, getting sober is?
Overcoming withdrawal.
Acceptance. Knowing you have a problem.
Vanessa said realizing that they have a problem, and that is the same thing as overcoming the denial. So yes, they have to take responsibility and admit that, yes, my drinking is why I ended up getting a divorce and not having a good relationship with my children. It wasn't because I had a nasty ex-wife, it was because of me. You have to take ownership. And until you can get past that denial, which I think is extremely hard for them to do, you just cannot move on. So you can put an asterisk by that, that's important information. And I would bet, I'm not a gambler, but I would bet that every single one of us has had a loved one in our extended family or someone that we were personally close to who has had either a drug or an alcohol problem that has brought them harm and their family harm. That's how prevalent it is. Alcoholics Anonymous isn't for everyone. There's a big emphasis on the higher power, the spiritual assistance, and some people are put off by that. And you know, one of the things that has happened in our society in the last probably 20 years maybe is that there are more and more people, I guess, who are not very active in church or they're not at all, that they don't associate with, you know, they feel that how their life turns out is up to them only, and, you know, they do not connect with Alcoholics Anonymous. And that's, you know, that's their right, because it works for some people, it does not work for others. They can have one-on-one counseling, they can go to some group therapy that's not AA-based, and there are medications, there are some newer medications out there that are helping people quite a bit. One of which is naltrexone. Naltrexone is a little bit unique in that it decreases cravings for alcohol and also opioids. It's not 100% like most drugs. It only benefits about 40%, but this is a drug they can take while they're drinking. They do not have to be abstinent to take this drug. And what a lot of them will say is that it just wasn't fun anymore. So they can take their opioids or they can use their alcohol and they just don't really get high. So they're not getting the high that they're seeking or the drunk that they're seeking. They're not getting blitzed or whatever. So their blood alcohol is still going up. They're still engaging in risky behavior, but they tend to drink less, and it's easier for them to drink less and moderate their drinking because they it doesn't affect them in the same way. Okay, so disulfiram, if they do drink, they're gonna get deathly ill. And they're gonna wish, maybe, I won't say they wish they were dead, but they're going to be so miserable if they mix if they take this medicine in the morning and then later that day they decide to have a few drinks, they're gonna pay for it. So, and they'll probably only do it once. So they'll do one of two things. They'll stop drinking and continue taking the medicine, or they'll stop taking the medicine and continue to drink.
Do you think people try it just to see if it actually affects them? Like they just have to try it?
Hunter
This
asked,
really make me sick.
Hunter asked
I mean,
if, you know,
my
that's
name.
kind of personality, like, you tell me this is gonna make me sick, yeah, is it really? If you're one of those risk takers, you might try it once just to see. And I would say, I don't know, I think most of them take it pretty seriously, because they're really, should be very well educated on how bad it makes them feel. I have not seen anyone who took this medicine and drank personally. Have any of you? No? Okay. I think they mostly are afraid of it. But I'm not sure how many of them actually take it either. So just because you get a prescription doesn't mean you take it.
That's true.
So, with alcohol, they also are sometimes prescribed a long-acting benzodiazepine. The one that you would want to know about is chlorodiazepoxide. That's it's in the book. And it's a taper. They don't take it long-term. The naltrexone and the acamprosate, they can take long-term. The chlorodiazepoxide is really to help during withdrawal. And the clonidine, I add a fourth medicine up there, put clonidine up there. Clonidine decreases the nausea and vomiting and sweating that goes along with withdrawal. So it makes it a little less painful. They can use the naltrexone just to decrease the cravings. The acamprosate can be used to decrease cravings, but only after they've gotten sober. So it's not a withdrawal medicine per se, even though I have it on the slide, it's a staying sober medicine.
Which one's that?
The one that starts with an A, acamprosate. And that's a pretty new drug too.
Is it eligible?
Oh, you don't, oh, yeah, it's under alcohol, isn't it? No?
It's on our slide.
Oh, it's on the slide, but I just added it? Okay, so you all will need to add that. ACAMPROSATE.
Is it?
And it's to decrease cravings after they have been off of alcohol for, probably a week.
And then electrophone, that's decreased cravings, but why they are addicted, or?
Correct. The naltrexone, they can start it while they're still drinking.
What was the clonidine for alcohol?
The clonidine
Less
for both
painful.
alcohol and opioids cuts down on kind of the misery of withdrawal, the nausea and vomiting and the sweating. So it just makes it a little less uncomfortable to withdraw. So it's a kind of a short-term situation.
So would there be a time where you'd have the acamprosate and the naltrexone at the same time?
The question was, would someone take naltrexone and acamprosate at the same time, and that's no. Because you cannot take naltrexone or you don't take it, it doesn't work when you're sober, and acamprosate you don't take until you haven't been drinking for a period of time. So this slide about the medicines is gonna be probably important on your exam, no surprise to you guys. Under the opioids, buprenorphine, is a Schedule II drug. I think it's an opioid antagonist and agonist, so it actually has a little bit of opioid in it. It makes them feel, a little bit like they're getting their opioid, but it reduces their risk for respiratory depression and that sort of thing. Methadone, also Schedule II, it decreases cravings. It is a long-term dose of morphine, similar to morphine, only it lasts a long time. So it is a drug that can be abused. It can be crushed, it can be sold, people will sometimes abuse it. A lot of rehabs won't prescribe it, but others will. Kind of depends on their philosophies, if they think it's worth it. If it reduces overdose deaths, they usually give it. If they have a lot of overdose deaths in that area, they usually give it. Places like San Francisco, New York. I don't know if there are methadone clinics in Oklahoma or not.
There is.
There is. Somebody told me there is. Okay. I'm not surprised, but there was a time when it was hard to get. Although from working in the ER, I would have people come in that had prescriptions for it and were on it. So I knew they were getting it somewhere, but I didn't know if they were having to go to Kansas. Okay. We lost a little time with the lecture capture not working. It still has green lights, but they're not blinking. I don't know whether to touch it again or not. So I'm at a dilemma. You know how Mr. Baird said that 40 minutes of his just disappeared one day? I don't know if the lights, well, that happened to me too, and I don't know if that's the light's not blinking or not. I think it might be. I think I'm gonna turn it off and start it.
There's a lot, actually.
Okay, they're blinking again, but I don't know how long they were off, so. Okay, stimulants, generally, they're gonna be kinda anxious when they stop using stimulants and depressed. So they might be on an antidepressant, or they might not be on anything at all. Sometimes, some doctors will prescribe an antidepressant for them for 6 months or so, some may not. Hallucinogens and, the marijuana substitution and hash, notice I tried not to say that word, phenols or whatever, because I knew I would butcher it.
Okay.
So, usually there's no substitution therapy for that. So the sedatives, and I'm talking about things like, Xanax, and also, maybe some sleeping pill things, the roofies, which are not legal in the United States anymore, is on this list. They can probably be purchased, just like heroin's not legal, but it can be purchased, so, they increase the GABA in your nervous system, which has a calming effect. Barbiturates, there's less and less barbiturates out there. I don't even remember what those drugs are. Phenobarbital, I think, and phenobarbital. There, less doctors prescribe barbiturates if they can get away from it, because they're more habit-forming, even more addictive than the benzodiazepines. So, the effects depend on the dose and the potency of the drug. So there are a lot of different drugs. There's lorazepam, alprazolam, diazepam is Valium. That, they're all out there. Okay. So the people that take these medications that abuse them, if they're prescribed an anxiolytic, it's usually a low dose just to reduce their anxiety so that they can function better in life. If they're taking it to excess or buying it on the street, they're taking so much of it that they're getting kind of euphoric on it. They also, if they mix it with alcohol, there's additive effects. So they get respiratory depression easily if they're taking them both together, but you can get respiratory depression if you take enough of these types of medications on their own. You can die from respiratory depression. Heart rate usually slows down a little bit, and they should not go through withdrawal without medical support because they can die. And it's a lot of times from the respiratory depression, lack of oxygen to the brain going into and the heart can lead to the seizures. Okay. Inhalants. I did not realize until reading a little bit more about inhalants. I learned a little bit working in the ER, but it's a lot more common in teens and preteens than I realized, which scared me. This age 12 on here, that's very frightening to me. It's cheap. They can go buy inhalants cheaply and legally, and that's why young kids tend to try them. Boys, I guess, are more risk takers usually than girls, so they tend to do this more than girls. Gasoline, I think, is still the number one according to our textbook, although the glues and the paints, the spray paints, and all of that, keyboard cleaners, those things are also common. I don't really know the difference between huffing and bagging. I think maybe huffing is they just inhale it as they're pushing the button. Bagging, they press it, fill the bag with the substance, and then put the bag around their face and inhale it. They get very staggery. Staggery is not a real word, but it's one of my favorites. The real word is ataxia. So they feel hilarious, everything's very funny, or very excitable, they can't walk a straight line. It decreases the oxygen to the brain, and they can choke on vomit and die. They can have permanent brain damage with long-term use. I think this is very addictive too. They can suffocate. What you usually see, let me see here, on inhalants is that death most often, and I would write this down, is from cardiac arrhythmia / cardiac arrest. So if they show up in your ER and they've got this little ring of silver paint around their mouth and they're acting just totally bizarre and they cannot walk without assistance, and you would want to get that person on a cardiac monitor very quickly, get them some oxygen, get their vital signs, the usual things. But they can go into an arrhythmia, and that's often from lack of oxygen, because this substance is taking up the place of oxygen in the blood. So, and your heart's a big muscle, it requires a lot of oxygen to work.
What is arrhythmias and what else?
Arrhythmia or cardiac arrest, both are cardiac.
And you said telemetry, vitals and O2.
Well, I said, a cardiac monitor, but yeah, some sort of, I want the rhythm right in front of me, so generally, we're talking ER, it's a cardiac monitor. And, you know, you're gonna establish an IV, you're gonna, get ready for any kind of emergency to take place. But the first one that is most likely to happen is cardiac. They're not as likely to have respiratory depression like alcohol and opiates. They're more likely to cardiac arrest. Okay. So opioids, legitimate use is for pain relief. There's times after surgery and for different kinds of situations, cancer and various instances, people have legitimate use for pain relief. Opioids, they used to prescribe for a month or 6 weeks after surgeries. Now it's more like 4 or 5 days, and then they switch it to something else. So they're trying, you know, we've learned that people who start taking opioids for a legitimate reason sometimes get addicted very quickly, even if they don't double up on their medicine. If they're prescribed 2 or 3 weeks of Lortab 10 every 4 hours, they're going to get addicted. They're physically going to get addicted. So you don't see Lortab 10 much anymore, and you don't see it every 4 hours, and you don't see it for a month. But we did not so long ago. It can be injected, snorted, swallowed, smoked, transdermal, skin popping, or inserted rectally. I learned about the rectal by watching Interventions. So, it relieves pain and or anxiety, causes euphoria, which is very short-lived, and then drowsy and nod off to sleep with central nervous system depression. If they're overdosed on this or even heavily dosed, you'll see pinpoint pupils, shallow respirations, hypotension, probably slowed respirations. This says respiratory rate less than 12 per minute. If somebody came in and I've had reason to think they had been taking opioids, if they're breathing very shallow, if their O2 sat is 88 and their respirators are 12, I still think they're in respiratory depression. Okay? Because 12 is the bottom number of norm. So it's like, you look at their symptoms. You look at what's happening with that person. How are they tolerating those 12 drugs? If they're very shallow, they're probably not getting a good enough oxygen sat. So you look at both the rate and the depth. And if they're stuporous probably because of inadequate oxygenation. So at that point, you're gonna have to give naloxone. And they may require a ventilator. Naloxone is the rescue medication. Often has to be given repeatedly because of the short half-life. And at the end, when someone is in the very latter stages of overdose, the pupils dilate, skin becomes cold, and they're likely to stop breathing all the way. So you can't give one dose of naloxone and send someone on their way, because it's gonna wear off, and that opioid might not wear off for, 12 hours. The naloxone may wear off within 15 minutes. So you're probably gonna have multiple doses. Okay.
This is Martinez. We have a question in Tonkawa.
Uh-huh.
They want to know, is there a maximum number of times you can dose that?
I don't know the answer to that.
Okay.
I have seen it given and participated in giving it, 4, 5, 6 times, but I don't know if there's a maximum. I don't, that would be something that would be interesting to look up, but I don't have the answer to that.
Is there a
Okay,
standing
thanks.
order for it like O2?
Is there a standing order? If you're working in an ER, yes, there's a standing order, the ambulances. Actually, an OU football player who grew up in Enid, was taking, opioids for a back injury that were prescribed to him. He was gonna go to the NFL, he was being scouted already. He loved football from the time he was a very small child, he lived, breathed football. And he realized, his back injury was pretty bad, but he realized if he bought more Lortab on the street and took a bunch of them, that he could fool his coaches and his trainers and his doctor even, and into letting him play. And so, cause he wanted that NFL career more than anything. Then one night, I don't know how much he took, he was at a friend's house in El Reno, in their den in the basement, and they had some beers, and it got late, and they drifted off to sleep, and the next morning, he was in a coma. They called the ambulance, and he was still alive, but before they got him to the hospital, he died. So his father was an attorney, his mom has worked for, gosh, that's been about 10 years ago, and she's been instrumental in getting naloxone standing orders and the accessibility, because that ambulance didn't have it. Not only did they not have any, they didn't have anyone trained to give it. They didn't carry it. And that was the case 10 years ago. So she has made it her life's work to change that. Okay. It says you can give up to 10 milligrams of the naloxone to an adult, and those doses are 0.4 milligrams up to 2 milligrams. So that would be 5 doses if you gave 2 milligrams. I think we gave 0.4 was our usual. So there is that's out of your drug guide. Thank you, Victoria. Okay, so the term going cold turkey refers to leg spasms that develop when people are withdrawing from opioids or kicking the habit. Those are old terms. And actually, the opiates came to the United States in the 1800s. We were bringing in workers from other countries, and primarily China was helping build the railroad, Chinese immigrants. And opiates had been in use for 1,000 years over there. So I think they usually smoked it. We probably invented injecting it. I don't know that. I'm just making it up. But so it's been around a long time. So these terms, going cold turkey and kicking the habit, have been around a long time. People get runny nose, muscle aches. They feel like they have the flu. They're very irritable, nauseous, diarrhea. Lasts around a week. Says the peak is about 72 hours to withdraw. It could last longer than that, I don't know. So that's the acute phase.
So that's the peak of their symptoms is around 72 hours?
Yeah. The peak of their misery is about 72 hours. Okay. I'm gonna give you a 5-minute bathroom break. I apologize for how